Going to the answer, we have to understand what is the risk factor for the sudden cardiac death in HOCM patient. As you can see, these are the major risk factors. If the patient is having prior cardiac arrest, spontaneous ventricular tachycardia, and a family history of sudden cardiac death, this is a major risk factor. Minor risk factors are unexplained syncope, if the thickness of the ventricle is more than 30 millimeter, abnormal blood pressure, ventricular non-sustained tachycardia is there. So basically, this falls into a high risk category for a sudden cardiac death. A strong family history with interventricular septum thickness more than 31. So this patient ideally should have the best thing, that is what we can call as a AICD. So this patient was basically put on the AICD primarily to control. The patient's age is 25 and there is a strong family history of sudden cardiac death. Suppose this patient has put on the AICD. Now what are the chances that patient is likely to have cardioversion or a shock during the 1 year? It is estimated that if patient is having the history of sudden cardiac arrest in past, the chances of event or recurrence of arrhythmia is in the range of say 15 to 20%. But this patient had himself no history of cardiac arrest in past, it may be in the range of 10 to 11%. So it is really beneficial if this kind of patient is on AICD. Now just after this is a little bit of discussion about the HOCM. These are different types of HOCM which classically described. This is only the anterior septum is involved, anterior septum and posterior septum is involved. This is the lateral wall also is involved. This is basically the short axis. It's always the posterior or the basal septum is spared. Some patients may have anterior and the posterior basal septum free. This is very important. Apical HCM also we have to understand, it is a typical ECG changes, very benign prognosis, no resting obstruction, and if you do a LV angio, you have a spade-like picture. It's very important to differentiate hypertrophy from the athlete heart. The athlete heart may have a hypertrophy. If you compare, the LV cavity will be very small with HCM. There is unusual pattern of left ventricular hypertrophy. LA enlargement is very classic with HCM. There is a strong family history. ECG abnormality is always there. There is an abnormal filling pressure. So these are the things which can differentiate athlete hypertrophy from an HCM. Sometimes patient may have a senile or a old aged hypertrophy, as you can see. Here there is many a times a hypertrophy where there is an obstruction. If there is a typical HOCM, whole part of the anterior mitral valve leaflet is dragged. If it is of senile nature, only the tip of the mitral valve is dragged toward the septum. This is how one can differentiate. There are some other features also which can differentiate between these two conditions. Lastly, familial HCM is very important. If you really want to know that family person is going to go for a HCM or not, the best way to do a tissue Doppler imaging. And if tissue Doppler shows a reduced velocity of the EA import, then there is reasonable chance that patient can have left ventricular dysfunction or a HOCM in the later part. Regarding the management, as I have told, the best management, the comparison is very important. Surgical myectomy, alcohol septal ablation, dual chamber. There is no role of dual chamber pacing. Alcohol septal ablation is the primary thing, though there is high chance of ventricular, AV block and a permanent pacemaker. This is a procedure which is not available or not commonly done. It is done in a specialized center. Otherwise, the mortality or the risk is really going to be very high. I will not go into the detail. I will conclude at this time. Thank you.